Welcome to our panel discussion following on from the screening of Medicating Normal. For those of you just joining us, my name is Janet Shaw and I'm the manager of Reconnexion. Reconnexion is a Victorian not-for-profit service, and for over 35 years we've been working with consumers and health professionals to provide benzodiazepine withdrawal treatment, support, information, resources, education and training and research, all with the aim of increasing awareness of benzodiazepine risks and supporting their safe use. Joining us in hosting today's screening is NPS MedicineWise, who are committed to promoting the quality use of medicines in Australia. When Reconnexion decided to host a screening of this film, we drew up a dream team of panelists for this discussion, and we have actually managed to get them all to join us today. To kick things off, we'll be talking about real-time prescription monitoring, which will soon be mandated across Australia. In Victoria, SafeScript, a prescription monitoring system, has been up and running for around 18 months. And we'll start by hearing the thoughts of Dr. Killian Ash on prescription monitoring systems.
I suppose services like that always have their uses, but we need to be mindful that there's good and bad to them. The reality is that there needs to be a shared decision-making between consumers and doctors. And as Caroline said, that we as the medical professionals up our game in terms of the education provided. Benzodiazepines as a psychiatrist are a big part of my life. Here in the hospital today, I'm a ward round. There are profoundly ill people for whom benzodiazepines have been a mixture of either greatly alleviating in terms of profound suffering or life-saving in terms of catatonia and alcohol withdrawal. So in the short term, these are essential medications. And when those people regain their capacity, a huge focus of mine is to reduce their benzodiazepines over the course of the admission to hopefully cease them before they leave. And that's short-term use. And in my private clinic, I often inherit or people come along to see me who've been on them for years. And again, we start that journey. A program like SafeScript, for example, in Victoria, can help us up our game in terms of keeping an eye to who's being prescribed what and where, but we need to be mindful that people get addicted to these for all sorts of reasons, including those that are acquired outside of prescribing. You know, that's a huge issue, that everybody can access benzos if they want to. And so one of the things that I'm cautious of with SafeScript is that I've seen very vulnerable people suddenly get cut off, which is not only life-threateningly dangerous, but a really punitive approach. So more services like Reconnections help us to humanely address the very understandable reasons why people get addicted to benzodiazepines, which to some part are from inappropriate prescribing, and from others because people out there are suffering and they will understandably do whatever it takes to ease that suffering, and often acquiring street benzos is one of the quickest ways to that.
I'm glad you raised that, Killian, actually, the question of people abruptly stopping. James, I want to just ask you a question here. So one of the services that Reconnexion offers is a confidential support line. Can you tell us what's the support line noticed in recent times that has been a result of SafeScript?
Yeah, we've definitely noticed that there have been an increase in people calling into the support line and saying things like, my GP's cut me off, I've been red flagged, I'm not able to get the benzos that I need. Some patients are calling in and saying, you know, I've got a couple GPs because I'm ashamed to tell my main GP the truth about how much I've been taking because I've been really struggling with this. And, you know, we're having to tell people, oh, you might actually have to go to the hospital because you're on a substantial dose, you're at significant risk of a seizure. It puts them into a really sticky spot. On the plus side, also, we are observing more calls from doctors themselves who are saying, oh, I've just inherited this patient, or this has popped up as an alert on SafeScript. Can you give me some advice on how to manage this? And we love when that happens because, you know, sort of like what Killian is saying, then we can give them some advice about how to really do a safe gradual dose reduction within the community for that person. And it doesn't have to be punitive and scary and a shaming experience for the client.
Yes, I'm glad you raised that. In fact, I think from a service provider's perspective, we wish all psychiatrists were like Killian, and particularly when it comes to discharging from hospital. Just on that point, though, looping back to the film, the Medicating Normal documentary there, it really does. There's quite a strong focus on psychiatrists in that film, and that and psychiatrists with quite a heavy reliance on psychiatric medications. We know that the American healthcare system is, in a lot of ways, it differs from ours. It's not the same. It's just that there are parallels. And one of the examples of that is the idea that normal is associated with comfortable, so that if you're uncomfortable, it needs to be treated. I want to throw a couple of questions here. One will be to Killian about whether you believe there's an issue with prescribing by psychiatrists here. But I'm going to first of all start with a question to Hester or Caroline, as GPs. Is it a thing that you notice in practice that people come to you with an expectation that you can fix their uncomfortableness?
Yep, I'm happy to speak to that. I think that increasingly people are experiencing sections of distress in their life, and it's a complex situation which reflects the complexity of the big world around them. And often when they present at your surgery, they're hoping that you can remedy that with a solution. And I think that there's a little impatience sometimes that things can be done quickly, just as we attend to our mobile phones quickly and we attend to other things rapidly. We also expect the delivery of a solution in a medical sense. So I think that from a consumer point of view, they're hoping that you will have some solutions there. And I'd also say that the GPs often are the front line of the mental health system in this country rather than psychiatrists, because in America, you can often have a faster pathway through to a psychiatrist if you've got the access. But in Australia, a lot of mental health anguish is dealt with by general practitioners, and it's often only people who have more severity with their presentation where they go through to a psychiatrist. So we see a range of people, and I think roughly 70% of my practice, in terms of the people I was seeing, had a mental health component with each consultation.
Wow,
I wanted to,
sorry.
Yeah, which was done in the Beach study. So I was quite shocked. I knew I was doing quite a bit of mental health.
Yeah.
But people often don't just come in with one problem. They'll come in with a mental health issue as well as something else.
Absolutely. The evidence is there around the increasing rates of presentations of mental health issues, which in one sense is great because it means that people are seeking help, but people also have quite often a number of different issues going on. Look, I wanted to say for myself as a human being, I don't like pain, I don't like discomfort, I don't like unhappiness. I would love a quick fix, so I totally get where people are coming from. But there's a when I think about it, I think about this as we're trying to treat life ache with a tablet, and it's just not possible. And we have a system, and look, the system, in some ways the system is good. We have access through Medicare and through PBS to medicines and to healthcare. But the problem that we have is that, yes, we have cheap medicines, but where do people actually access the support with counselling and other forms of non-pharmacological therapy that we actually know work, and that can help them to manage their life ache better, or help us to manage our life ache better, and so there are system issues there. And Caroline, you're absolutely right, and Janet, you were saying this as well. In general practice, we're busy, and we are limited in what we can do, but also our patients are limited in what they can access, and so it can feel you want to help, and so the thing that you can offer is a medication, because people can access it at a price that they can afford, whereas others don't. Other forms, they're harder to access, and it does depend on your background, on your finances, and where you are in Australia. It's even harder for people in rural, regional, remote Australia as well.
Yeah, that's right. The expression life ache, it's really good that you've brought that in, because I think that was one of the really profound messages in the film. Like, I wish someone had just said to me, it's normal, you're going to feel pain and grief now for a while, and then you process it. And the idea that has to be put off for a very long time. I do want to now loop back to Kelly in that question about prescribing on the part of psychiatrists. Do you have thoughts on that or what you see?
Sure. I mean, look, you know, it's easy bash psychiatrists. I think, like GPs, it's a very difficult job. We're inundated. There aren't enough of us. We're not adequately trained. And people come with demands and expectations, and it can be tricky to balance. So too, do we also inherit people from other practices or who come to see us who've already been on huge doses of benzodiazepines for years. So, you know, in the American model, and again, this isn't about America bashing either, but I think what for me was very poignant about the movie was so many of what has destroyed America as a society and culture was evident, but didn't get talked about. The military-industrial complex that sends people off to war and systematically destroys humans and then medicates them on return. You know, the pharmaceutical and medical evolution over there, which is probably underappreciated, undertreated doctors, and then a whole population who are left in abject suffering as their government and society abandons them. So there was a lot of layers to this that maybe didn't quite get teased out. There was a bit of blame the psychiatrists, blame the medication. And to that end, I'll say, sure, there's loads of psychiatrists, GPs, and everyone prescribing too much benzodiazepines. But I think we need to be really mindful of looking at all the systemic factors that lead to these issues. People are deeply suffering. The world is difficult. And there's a lot of people who are mentally ill and in pain. And I just to say as well that, I mean, I educate the medical students, and I think the appreciation for the importance of managing medications carefully is increasing. And I just warn my junior doctors not to be a walking prescription pad, because if you don't develop psychotherapeutic skills, then you're only a fraction of what you should be as a psychiatrist. Problem is, as Hester alluded to, we as doctors aren't educated enough, even as psychiatrists, in bringing our therapeutic skills, and neither is the health infrastructure set up to provide the level of psychotherapy in the community that people require. And so inevitably medication comes to the fore again.
I think it might be really good to hear from David now. And David, you've been really politely putting your hand up. So I think that your perspective here will be really interesting, because not only the GP perspective, but as an addiction medicine, what would you like to say?
Look, I used to be a GP for many years, and now my perspective is very much clouded by a specialist drug and alcohol industry. But certainly our hospitals are part of the problem in the way that they prescribe instant relief medications for people who are experience anxiety, agitation, insomnia in hospital. So we often initiate these horrible medications. But what we never really do, and there's been a discussion of talking about the side effects, but what's not really discussed is that benzodiazepines are intrinsically like other GABA agonists, drugs that you lose the effectiveness from. So just like alcohol, no one expects to drink alcohol every day and have exactly the same experience. You want to increase the dose to get the same experience. And benzodiazepines are very toxic substances because you develop tolerance to them. So this is the major problem with benzodiazepines and others like pregabalin, the gabapentinoids, exactly the same. Once you've established tolerance to them, you feel as though you are trapped. You want to get off them or you want to increase them. And unfortunately, they're very difficult. And there was a fragment of the film at the very end which said, do not stop these drugs suddenly. There is an art in getting off the benzodiazepines, as there is in the opiates, as there is in the gabapentinoids, which requires information. And I'm hoping that people will come to Reconnexion for that purpose, because most GPs are not trained in discontinuing these agents, any of these dependence-forming agents. So we advise a lot of GPs about how to do this. We spend a lot of time getting people off seductive medications. And we're not just talking about the benzodiazepines. There's a new man on the block, quetiapine, which is so much like a benzodiazepine in its seductiveness, as is pregabalin. So these are agents that are sold to GPs without mention of the risks of tolerance developing, and therefore the failing to do what you started them for in the first place. So they are
Yeah,
different from any of the hypertensives, cholesterol agents and other things. Yes, Janet, sorry.
Yeah. I'm really glad you mentioned about that, how highlighting the fact that it's so important to have a very gradual withdrawal. That's bread and butter for Reconnexion. And we've got clients who've been withdrawing literally for years, little bit by little bit. I think one of the most poignant images in the film was someone shaving tablets, physically shaving tablets. And you just think it shouldn't be like this. Natalie, I'm just thinking as we're talking about the actual process of withdrawal, I'm wondering whether you want to add anything in there.
Yeah, I think that is the biggest draw card when we talk about informed consent and understanding the repercussions of taking these pills. We talked about that earlier, but the biggest issue for me, for example, it took 3 or 4 years to taper off the medication. And it was also, there was a lot of intricacy involved. I had to transition from the 2 type of benzodiazepines I was on to another one with a longer half-life. And I have been listening to these conversations about GABA receptors and half-lives, and I had to educate myself on this as a consumer. There was no discussion of this in the lead up. So I think the withdrawal process for me is like the most important thing people need to be educated on. If you know you're going to be spending years doing this, it's a big deterrent. So yeah.
Yeah, so there should be some kind of exit plan from the moment of the first prescription, really.
Yeah, I mean, and the other thing is I was prescribed by a psychiatrist. So there is that element of, I was getting all the other therapies recommended, but despite that, she prescribed me 2 benzodiazepines for years. So it is an issue across the board, I think, regardless of the doctor's area of expertise.
Thanks, Natalie. I wanted to, oh, sorry, go.
Oh, I was going to say that interestingly enough, a lot of the education to doctors and allied health professionals is via pharma companies sponsoring events. And I think that there's a lot of confidence that's built around prescribing, and there's not a lot of confidence built around de-prescribing. And in fact, one of the challenges that we now face is how do we start de-prescribing when people are on a complex range of medications, some of which should have been knocked off the medication list long ago, but people are actually very nervous about taking them off because they might confuse the emergence of symptoms with withdrawal as being a re-emergence of the original condition. And so people need to be far more confident and educated around how you de-prescribe.
I think that's such a good point, Carolyn. And I think maybe James might want to add something there with experience in terms of our, not just the Reconnexion clients who are withdrawing, but also presentations to GPs.
Yeah, I guess when SafeScript rolled out, this makes me think of SafeScript because when it rolled out, we were asked to deliver a whole lot of training for GPs, and also we had a big boost in secondary consultations because I think Caroline's absolutely correct that doctors are well trained in what to look for and what to prescribe, and then when it comes to de-prescribing, there's a real gap, and some of the reasons for that gap are that sometimes you look at an older client, maybe they're in their 70s, and you think, is it really worth it? When in fact, the evidence tells us that it is still worth de-prescribing even at that age because they're at risk of falls. And sometimes, you might pick up a patient from somewhere else, someone who's retired, and then they come to you and they're on this great big wrecking dose of benzos. And so it means approaching a really uncomfortable and difficult conversation with a patient. Sometimes patients get angry in these sorts of circumstances. So, I guess there's a real gap there. There's a gap between the prescriber's knowledge of how to de-prescribe, and that's something I think SafeScript in particular is bringing more and more into sharp focus. And there needs to be quite a lot of support for doctors around that, because it's not just the patient, but it's also the doctors who are getting into a fairly difficult situation here when 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 it's getting flagged and they're realizing, oh no, this is a bit of an issue and I'm not entirely certain of how to proceed.
Can I add that I think Natalie's
sorry,
point was really important, that these agents are not equally dependence forming. And the more rapid onset, the more euphoric they are, the more likely they are to generate dependence and escalating doses. And if I think we don't have any understanding really, or little understanding amongst, unfortunately, psychiatrists, that they often use very short-acting benzodiazepines in psychiatric settings without recognizing that this agent will generate bad behavior just to get the euphoric benzodiazepines. So we're actually getting in our hospital wards where the deprescribing before discharge, which Killian mentioned, is really hard because patients are manipulative, of course, because these drugs make you feel great. And while you're on them and you're getting adequate doses, you do feel better until, of course, you get completely used to it. So Natalie's comment about there are certain agents which are really hard to get off, and you have to change to longer acting agents, which are a little bit more boring, but you can shave off this deprescribing process is a lot easier with the long acting agents.
I would actually just like to mention there, for me, I know from a medical standpoint, you're explaining a euphoric high. When I was transitioning from a shorter acting benzodiazepine to a longer acting benzodiazepine, I wasn't doing it for a gratification. I was doing it under medical advisement from Reconnexion. And I was doing it because I was terrified of some of those risks we've talked about seizures, about rapid withdrawal, about my overall health and well-being. For me, when I look back at my benzodiazepine use, it was never fun. It was never euphoric. It was what I did to like feel normal.
Yeah, I think it's really interesting. That's right, Natalie, I must agree. But I think it's interesting, David, what you said before, because you said a word that sort of made me think, oh, and that was manipulative. And I think that certainly in terms of providing the services we provide at Reconnexion, we see a whole lot of different kinds of presentations. I'm thinking again of something that Killian mentioned earlier, but I think this raises also that sometimes people need to resort to finding benzodiazepines on the street because of their circumstances. Perhaps I think James, it was, you said that people don't always tell their doctor that they're also getting it elsewhere because they're too ashamed. The idea of stigma. So let's think about that for a sec. And shame, it's a really big player in this whole story. Hester, you're really nodding. Would you like to say something about that? We know she does.
Sorry, I clicked on the wrong thing and everything disappeared. Sorry, I turned myself on mute. Look, yeah, it is so core to this, and it is the shame itself means that people don't seek help, and it makes people unwell. That experience of shame, and I note in the chat there that people have talked about disenfranchised or marginalised communities, so that yes, this is core. And I know that we as GPs don't mean to discriminate or stigmatise, but we do. We don't even think we're doing it, and we try not to, but sometimes we do. Or people that have experienced stigma and discrimination are very, very sensitive to it, so they will hear it, even if it's just a tiny bit that we don't mean. And so it really needs to be front and centre, and the language that we use needs to be front and centre to help people actually engage with this and understand that people are terrified quite often. I don't know, Natalie, if that was your experience, but can be so scared about changing what they're doing because they've tried before. It was really awful. There's a whole heap of dynamics going on there. How am I going to manage my life if I don't have this? I'm going to feel terrible. I'm not going to be able to take care of my kids. I'm not going to be able to go to work. All those things that can happen for people. And we do need to understand that you've got to work gently over time together. And have that really strong treatment team around you as a consumer to help you do that. And it does take time. And what I'm always saying to people is it does take time, but we're going to get there together. It's going to be okay. In the longer term, you will feel better. But I don't underestimate how hard this is going to be for you. But as your doctor, I'm going to be there for you.
Thanks, Hester. That's also very much the experience we have at Reconnexion. But one of the things that this kind of raises is awareness. So it's not just awareness amongst health professionals, but awareness in the community. And Carolyn, I'm sure you've got something to say about this, and whether maybe as a community we've learned a bit about the road we're going down in terms of mental health and how it's portrayed publicly in terms of stigma. We're getting somewhere with that. Carolyn, have you got any thoughts about increasing good awareness in the community about these sorts of things?
Well, I think that our conversations are far more frank than they were when I started medicine 30 years ago. And I think that mental health is one of those conditions that people are more upfront about when they discuss their life situation. I think when it comes to medication, even the use of antidepressants has been largely destigmatized. But I think that there are things like benzos and opiates, which are still falling into the category where people are trying to possibly conceal their use from the wider community because they fear being judged. It's one of those things where, I mean, Hester was so right that we need to be very careful about our language and to be constantly championing that sense that if somebody has a situation with a medication, it's part of a medical condition, and it's just like having any other medical condition, whether it's you've got diabetes or you're living with high blood pressure or you're living with anything else. To me, I think we need to level that playing field. But it's interesting. I think a lot of people are far more upfront about what medications they're taking than they were before, which I don't know if the others think that, but I found that particularly amongst young people. People never wanted to admit when they were on a medication for mental health. And I think now people are far more comfortable about revealing that.
Thanks, Carolyn. Now, I'm going to flag, before we go to Killian and then David, we're actually almost out of time. So if we hear briefly from Killian and then David, and then I'll also ask the others for just a closing minute each of a thought.
Sure.
I can't believe it. Thanks, Killian.
Not at all. And just to say that while, of course, awareness amongst the community is key, it's not their job to be up to date on all these medications. I mean, as a psychiatrist, I've never prescribed a Xanax in my life, and I never will. There's no need. We doctors need to be better educated around medications and educating others. And we need to be better educated in saying no. Like, it's not up to consumers to arrive and set their own limits. People are in deep pain and distress, and they want something to ease their suffering. And so when they ask, like, it's not up to them to limit. Of course, we all need to work together, but I think sometimes we just need to be mindful of not consumer blaming. Doctors need to get their shit together, basically. I don't want to get into doctor bashing either. We have an impossible job. But I think the education bit is absolutely vital. And with that then will come hopefully a dissemination of better information to the community. But we live an insanely privileged life as healthcare professionals. People are out there with poor health literacy, maybe poor literacy itself. And so to ask them to be the ones to set limits here is not something that I think is reasonable.
Yeah, thanks, Killian. That's really well said. David?
Just 2 points I wanted to make. The first is that people who are vulnerable to dependence are much more likely to have trauma disorder of some sort, particularly adverse childhood experience. And I think that we're trying to medicate a very long-lasting, but not inevitably medication-sensitive anxiety disorder or depressive disorder. So I don't think people are very well educated about complex trauma disorders and the best way of managing them, and certainly medications are not the best way of managing this, and certainly benzodiazepines and opiates are not the best way of managing. The second thing with these medications, and the reason I do the work that I do, is because we can be optimistic for our patients. I think Natalie's story is exactly right. You can, by engaging with your patient, more or less guarantee that you will, in collaboration, get people off their medications and have them happier and healthier and more functional without the medications than they were when they were on them.
Thank you, David. James, do you have a last minute thought?
Yeah, just one or two things very quickly. One is that just around awareness, one of the things I think about is that there's always a bit of a power imbalance when a patient goes to a GP or a psychiatrist, and there's a bit of evidence that tells us that when a patient goes in and collects a script from their GP or psychiatrist, whoever their prescriber is, the act of that script being written and given is implying that you should keep taking this medication and that it's okay for you to take. That's the implied message. So I guess I'm just thinking that it's really hard for a patient to overcome that implied message and the very big power imbalance between the two of them. So I guess the main thing is what people can do is they can try to inform themselves, and they can call Reconnexion, they can call other services. There's lots of services available at the moment. Try to start a conversation with your doctor if you're uncertain. Why am I taking this medication? How long will I need to take it for? Don't be afraid to do it, because sometimes your prescriber isn't necessarily going to approach the conversation, and you might have to be the person to do it. It's not great that that's the world we live in, but that's the reality at the moment, and hopefully that changes.
Oh, very well put, James. Thank you for that. Carolyn, do you have a last minute thought?
Well, I'd like to see a lot more education for health professionals, because I think that, as has just been mentioned, that really it's very hard for consumers to sometimes go with a full sense of what's being prescribed for them, because they trust their doctor to have made a wise decision on their part. I think that GPs need a lot more training in mental health, and there needs to be a lot more awareness around the limited evidence base for treating mild to moderate depression or distress instantly with a medication. I still think it's used far too often as a go-to, as a quick fix, and we need to be far more cautious and far more holistic in our provision of care for people who are living with mental health anguish.
Thanks, Caroline. Now, Natalie, do you have closing thoughts?
Well, there's so many thoughts on this entire issue from multiple angles. I think it's just really important for doctors to pay close attention to their patients throughout any treatment and listen carefully to feedback that they might get throughout. When I think back to my usage, I actually flagged my concerns earlier on and they weren't acknowledged. So it's really important to pay attention to the patient and not go in with a veiled suspicion that they might be manipulative or have an agenda. They're really just trying to get better, and they don't have the same resources and education that their providers have. So be patient with that and be mindful of that.
Thank you, Natalie. I think that's a really just the perfect note to be ending the conversation on. And sorry, David, I know you wanted to say more, but unfortunately, I'm having to wrap up now. I think that the film actually raises, and some of them have sort of emerged in the conversation a little bit, raises a lot of issues that we just obviously didn't have time to explore today. For example, the question of medication amongst veterans and the impacts on family members and access to services. And I think particularly it's important to think about trauma, which is obviously something that we think is behind a lot of this. But we're out of time, and there really is so much to talk about. Just before we close, I just want to warmly thank the audience for joining us today. Thank you very much for your comments and questions that came in. And of course, unfortunately, I'm sorry we couldn't get to everything. I'd like to thank also, thank the panelists. The panelists, you've been wonderful. Thank you very much for making the time and for joining us today. I'd also like to thank the Reconnexion staff, and especially Erin Oldenhoff, who's the one who made this happen. Thank you, Erin, for organising the event. And of course, the Medicating Normal team for bringing us this really important piece of work. We think this film is really important and should help the conversation happen here in Australia. So thank you all.